Hello and welcome to ADN 253 MedSurg 3. This is your final course, your final MedSurg course before we go on to leadership and we go on to preceptorship and then of course graduation. When we're looking at this course, it's going to be held a little bit differently. The way in which the first class is going to be held a little bit differently. You should, if you followed the instructions, be basically looking at my presentation, the class presentation. It's the presentation that I gave in front of the whole class for 251. For this course, at least for this first class meeting, you're going to have all of this online, and the idea is that you're going to review the presentation. You're actually going to hear my lecture ahead of time. That way you can have the chance to understand the information, play back the information if you need to, use it to bring the information home. I do understand that one of the limitations with this is that you are not allowed to ask questions as they come up. However, the way that we're going to handle that is that as you're reviewing the presentation, as you're listening to my explanations, as questions do come up for you, you can write them down. You can look in your book for further explanation. And if you still have questions, of course, on Monday, when we come together for that first class meeting, bring your questions then, and we will go ahead and answer any of those questions that you may have. For this first topic, we're talking about the hematological system and disorders with the hematological system. When we're looking at the hematological system and disorders of the hematological system, we're basically looking at three big concepts. Concepts we've been telling you, I told you in 251, we've basically been telling you throughout the program, how do you study for nursing school, and we were always telling you concepts. When you're looking at concepts and concepts within nursing, we can look at concepts under the context or the definition. Basically, concepts are those things that we as nurses care about. When we're looking at diseases, if we're looking at that patient who has pneumonia, when we look at the concept of pneumonia, we want to know what, as nurses, what are we looking at that patient? What's going on with that patient physically? What's going on that is preventing them from maybe completing their ADLs, perhaps functioning, keeping their body in that homeostasis. We're looking at those concepts. So when we're looking at someone like pneumonia or something in that range, we're looking at those problems basically that came out with your NANDAs. We're looking for that inability to oxygenate. Sometimes we're looking at that cardiac output, which comes into the perfusion component to the concepts like that. So the three big concepts that we look at when we're talking about disorders of the hematological system has to do with perfusion, clotting, and immunity. When looking at the concept of perfusion, it can be described as the flow of blood through the arteries and the capillaries. We have the blood being pumped by the heart, going through the arteries and the capillaries. Remember, when the blood is going through those areas, it's that oxygen and nutrient-rich blood. So perfusion is basically that blood flow and how it delivers that oxygen and needed nutrients to the cells. When we're looking at the concept of clotting can be described as a physiological process where blood is changed from a liquid to a semi-solid. When we have the blood and the blood is clotting, of course, there are many steps that you either recall from anatomy and physiology, or you recall from the first year, or you read it when we had the assigned reading to refresh your memory on that. But remember, that first step along the clotting is that platelet aggregation, those platelets clumping together. Then the body takes over and it goes through the clotting cascade. But basically that entire process is how we change blood in its liquid form to its semi-solid gel form. And the last concept that we're going to look at is an overall concept for the hematological disorders in the hematological system is going to be that of immunity. Immunity is that physiological process that provides us as individuals that protection and defense from disease, from the disease organisms, the disease process itself. A lot of things have to do with immunity, has to do with the immune system, has to do with various things. When we're looking specifically at the hematological disorders and immunity, of course, we're looking at those white blood cells, right? The fighters against the disease within the circulatory system. Tissue oxygenation and perfusion is going to rely on that normal hematological function. If there's not a normal hematological function within the body, whether it's by a disease process, whether it's by an inherited factor, or something basically going on with those components that have to do with perfusion. In order perfusion to be appropriate, we have to look at both the contents, the plasma, we have to look at the lymphatic system, and we have to look at the actual cells themselves that are within the bloodstream, actually carrying on that transmission or that transference of those nutrients and that oxygen to the cells. When we look at plasma itself, as a reminder, remember to look at those components of plasma. Plasma is made up a large part of water. When we look at it, our bodies are made of water, right? The fluid within that plasma has a high water content. It also has a lot of proteins going in it. When we're looking at it, that albumin and that globulin comes into play. And we can't forget that in addition to the plasma, we have those ions floating around in it. Basically, those electrolytes are going to be those ions, right? The potassium, the sodium, the chloride. In addition with that, with the plasma, we have those clotting factors, the thrombin, the prothrombin. All of those clotting factors is what's going to take the components of that clotting cascade. And of course, we have plasma cells. We have some cells in the plasma. When we're looking at it, we have to look at the cells, the lymphocytes, right? B lymphocytes. Those are the actual plasma cells throughout the body, throughout the bloodstream itself. When we look at the lymphatic system, we have to remember about the lymph nodes, right? The thymus, the liver, the spleen, all of those things and all of the parts that those play with this. When we're looking at the components of the lymphatic system, looking at that plasma, looking at those macrophages, those white blood cells, the lymphocytes themselves. The lymphatic system basically has to do with immunity. That's the big system that we have to do with immunity, with protecting the body, with defending it from those disease organisms. It also has to do with fluid and electrolyte balance, filtering of the blood, transports fat and the fat-soluble vitamins throughout the body. When we're looking at the basic cells within the hematological system, within the plasma, within the bloodstream itself, remember we have some big components of cells that we need to look at when we're looking at those RBCs. We are going to want you to remember the normal values for your RBCs. Anything that you're looking at, we're going to look at normals. Remember, normals, depending on the facility that you're working at, may be a little bit different depending on the range that they're using. The ranges that I've used and the ranges that we're going to be discussing and talking about basically are those that are listed in your MedSurg test book. So when we're looking at it, the RBCs, and we're looking at the two different categories of normal. Remember, we have female versus male. When we're looking at the RBCs, that 4.2 to 5.4 million per microliter is going to be the normal for a female patient, adult patient. And when we're looking at the 4.7 to 6.1 million per microliter, we're looking at the range for a male patient. When we're looking at white blood cells, are normal for patients, both male and female, 5,000 to 10,000. When we're looking at platelets, our normal platelet, 150,000 to 400,000, normal for both the male and the female. All right, and our bone marrow. Remember, our bone marrow is where many of the cells actually take place. That's where the production of the cells occur. Our bone marrow, remember, is basically divided into those three parts. Looking at the red marrow, red portion of the bone marrow, when we're looking at that, that is the area where there's the production of the red blood cells. When we're looking at the yellow marrow, Recall that the yellow marrow is just basically that fatty substance. We don't have any red blood cell production at all in the yellow marrow area. When we're looking at the stem cell area is where we're going to get a lot of those various different cells created. When we're looking at the myeloid line, we're going to look at those RBCs. We're going to look at those macrophages. We're going to look at those monocytes. We're going to look at those neutrophils, basophils, eosinophils, erythrocytes. We're going to look at those platelet cells there. When we're looking at the lymphoid line in the stem cells, that's where we're going to have those lymphocytes. That's where we're looking at those cells that are basically dealing with that big immunity. We're looking at those T cells, those B cells, the killer cells. We're going to look at those various, the natural killer cells, I should say. We're going to look at those various different lymphocytes are going to be created there in the stem cells of the bone marrow. When we're looking at our patients, there's a couple different things that we definitely can take care of them for when they're dealing with procedures that have to do with the bone marrow. When we're looking at someone who is to undergo a bone marrow aspiration, that's where they're actually going to take that large needle in and actually aspirate some of that bone marrow out through a rather large needle. Probably the most common area that they do that is the iliac crest in the hip area. When we're looking at that for the patient, ways in which they're going to do that obviously is going to be an anesthetic or a topical anesthetic. Patient may or may not be sedated to some point, has to do a little bit with doctor preference, also has to do with how the patient can tolerate the procedure. When we're looking at that bone marrow biopsy, kind of the same areas that they go into, most likely the iliac crest of the hip area. If for some reason that site is not available for either the aspiration or the biopsy, they have been known to do it in the sternum area because they also can get bone marrow out of that area. So during the procedure, like I said, for both of those, kind of the same type of pre-procedure, intra-procedure preparation. We have a numbing area of the outside of the tissue, and basically they go in and they get it. The patient needs to be informed pre-procedure and education that happens. Basically, they're going to numb the outside, but they are still going to feel immense pressure. They're actually still going to feel the needle for the aspiration or the needle for the biopsy going in. Post-procedure, we need to be worried, of course, about bleeding. We need to make sure that we check that there's nothing oozing from the site. We need to monitor our patients. Of course, we need to monitor our patients for possible risks of infection because it is an invasive procedure. Being that it is an invasive procedure, of course, the patient does need to be consented by the doctor for this, and the nurse does need to witness that consent. All right, and a quick refresher on those red blood cells produced in the bone marrow. They're flexible. They're not a constant circle or ball formation. They're very flexible. They can go into various different shapes. Average lifespan about 120 days. When we're looking, remember red blood cell count, we've gone over that previously. Remember your hemoglobin, different for the female and the male. Female's a little bit lower. Same with the hematocrit. When we're looking at that hemoglobin, recall that hemoglobin is a protein included in the RBC. That's where oxygen can be transported to the cells, is on those hemoglobin proteins. When we're looking at the hematocrit, that's going to end up being a percentage of hemoglobin or oxygen carrying capacity on those red blood cells in the bloodstream. So when we're looking at the CBC, we're pretty familiar, pretty common with looking at the RBCs, we're looking at the white count, we're looking at the hemoglobin, looking at the hematocrit. We need to try to review and look a little closer at some of the other lab values that we see on the CBC for our patient. Some of the other RBC components, in addition to just the number of the RBCs, you'll see those numbers towards the bottom of the CBC that most nursing students, sometimes even new nurses, just kind of throw those out and say, I'm not going to worry about those. But we need to be aware and look at what those actually mean. When we're looking at the MCV, basically that gives us the average size of the red blood cells. um, in the collection that they've done. When you're looking at MCH, that's going to be the amount of hemoglobin per red blood cell. So it's going to tell us the amount of the hemoglobin protein component that's going to allow for that oxygen carrying capacity. When we're looking at that MCHC, that's a concentration of hemoglobin. Basically, it's the concentration of hemoglobin related to the size of each of the RBC cells. When we're looking at that reticulocyte count, which can also be seen there, that's a number of immature red blood cells. We're looking at a percentage from 0.05% to 0.2% of immature RBCs. These immature RBCs most oftentimes can then mature and turn into full functioning RBCs. So that's what we want to look at. Some of the other tests that we're looking at with our hematological disorders are the Coombs test. You may remember the indirect Coombs test from OB. We use that a lot in OB. It detects antibodies against RBCs that are present in the blood. We do it with our OB patients. We also do it before a transfusion. We're looking at that direct Coombs test. We're basically looking now for antibodies that are bound to the RBC. So with the indirect, we're looking for the ones that are floating in the serum of the plasma, but when we're looking at the direct Coombs, we're looking for those that are actually attached to the RBCs. Some of the disorders that we look at when we're affecting RBCs basically are anemias. When we're looking at our hypoproliferative anemias, basically these are the ones where we are basically not creating enough red blood cells. A lot of the different deficiencies that we can look at that play a portion in this is our iron deficiency anemia, when we're looking at our vitamin B12 deficiencies, our folic acid deficiencies. Potassium, we have a decrease in erythropoietin production. Erythropoietin, remember, if we have a decrease in that, it doesn't signal our bone marrow to actually create those red blood cells. Also, some of our hyperproliferative anemias, cancer, the inflammation going on with that. Oftentimes when we're looking at those anemias related to that inflammation, it's an aplastic anemia. Then we have our anemias that deal basically with red blood cell loss. Probably the most common that you're looking at and people are most comfortable understanding is someone who may be bleeding, someone who has a GI bleed, also someone who has hemorrhage, whether it was a traumatic hemorrhage or something that they've had from surgery, or perhaps it is a female with heavy menstrual flow. Those type of things, those type of red blood cell loss can cause the patient to become anemic. When we're looking at hemolytic anemias, we're looking at basically blood cells that are destroyed. They're destroyed early. Probably the most common that we're looking at that is our patients with sickle cell anemia. We're going to talk a little bit more later about sickle cell anemia, and we're looking at it. But in addition to the sickle cell anemia and the morphology or the shape of the cells being different, also they have the problem that they are actually killed off sooner than their normal 120-day lifespan. So there's a loss of those red blood cells. When we're looking at other disorders, of course, we have the anemias. We don't have enough of those red blood cells. We do have two disorders where we have an excess of RBCs. When we're looking at polycythemia vera, we have an increased production. We have an increased production not only in red blood cells, but leukocytes and platelets as well. Our patients with polycythemia vera definitely increase risk for clotting. We've got those clotting issues going on. Another disease process or disorder that affects red blood cells and basically too much iron in the body, hemochromatosis. This is a genetic condition in which the body absorbs too much iron from the GI tract, and therefore we have too much iron in the body itself. Medical management, when we're looking at our patient who is anemic, basically we alleviate and control the causes. If it's something from a deficiency anemia, we can give them supplements or possibly change the diet. If it's something where they're bleeding or hemorrhaging, we control the bleeding. Various different things. Some of the manifestations that they may represent with when a person is anemic They may be short of breath, unable to do ADLs. We may give them oxygen therapy because they don't have that ability to actually get that oxygen to the cells that it's needed. Volume and perfusion control. If they have an issue with anemic related to a lack of erythropoietin, we can give the patient erythropoietin. And sometimes blood transfusions. Definitely patients who are anemic, patients who are a little anemic, we don't oftentimes go right out and do that blood transfusion. The blood transfusion has a little bit to do with the numbers of the hemoglobin and how low it is, but it also has a lot to do with symptomology. So some patients who sit with a hemoglobin of 8, you may say, well, you know, my last patient with a hemoglobin of 8, they got transfused. Why are we not transfusing this patient? We have to look at the patient as a whole. Are they symptomatic? Are they used to being anemic? A lot of times if it's a chronic anemia, maybe it's a patient with chronic renal failure who is anemic related to that and related to the kidney failure. They very well may be able to function and not have symptoms with a low hemoglobin. Where someone who normally has a hemoglobin with a normal range all of a sudden drops down to an 8 or a 9, they may have those symptoms relating to the anemia, possibly dizziness, possibly low blood pressures, possibly difficulty breathing. Any of those things may constitute a reason why a doctor may order a blood transfusion for that patient. These are our nursing diagnoses basically. So basically when you're looking at that patient, what are the kind of things that you're going to see? Basically, they have the inability to carry those nutrients. They might have difficulty with tissue perfusion, whether it's tissue perfusion to the extremities, to the brain. They may have activity intolerance. Are they able to get that oxygen out to actually engage in those activities they need? Altered nutrition, less than body requirements. They might not be eating the necessary iron that they need, or they might not have the activity or the energy to eat. Risk for ineffective management of therapeutic regimen. Patients who are given iron. Iron can be very upsetting as a prescription to the stomach. It's very difficult to the GI tract. A lot of times our patients won't always take those medications. So are we having difficulty with them actually following through with what has been ordered? In the management of the disease processes where they have an excess of RBCs or an excess of iron, we're concerned definitely about clotting. Clotting issues in the smaller arteries, organ failure because of that clotting issue, the arteries that feed the organs having clots in them, so we have decreased blood flow to those organs, resulting in some organ failure. When we're looking at the polycythemia vera, some of the treatments that we're looking at for them, apheresis. Apheresis, if you think about it and look at it, it's a lot like the same concept of hemodialysis. With apheresis, we're taking out the patient's blood and we're basically removing or cleaning the parts that we don't need. With polycythemia vera, we have an increase in red blood cells. So during the apheresis process, we take the patient's blood out, we wash it, send it through a filtration system in which a portion or a percentage of the RBCs are removed, and then the blood is returned to the patient. In addition to that, some of the other things that we do for these patients, hydration, IV fluids. We have that thick, concentrated, sticky blood. We have to hemodilute them, and in order to hemodilute them, we give them hydration, right? Increase fluid in the bloodstream in the vascular space. Also, hydroxyurea. Hydroxyurea would be a medication that we can use for our patients with polycythemia vera. They have increased production of those red blood cells. Hydroxyurea is going to work on the bone marrow, work on the actual production of further red blood cells. In the management of the disease process that is an excess in iron, the hemochromatosis, one of the most common things that we do, once again, is the apheresis. They're going to go ahead and take the iron out of the blood. In addition to that, we do have some treatments that they use regarding the chelation therapy, where they give a medication or a compound in which the iron then binds to that and is excreted through the processes of the body. When we're looking at the concept of clotting and the way that the hematological system works in the process of the clotting, we need to look at the components of the blood, the platelets, clotting factors, as well as the anti-clotting factors that are present in the individual patients. A little bit of a review regarding the liver. Remember, our liver is actually the producing place, or the place where the clotting, anti-clotting factors are produced, as well as bile is produced in the liver. Liver also stores that iron, stores the RBCs, stores whole bloods, and very, very small amount of erythropoietin is in the liver. Remember, we're looking at the erythropoietin. We're looking primarily in the kidneys. However, we do have small amounts of erythropoietin from the liver itself. Remember, the liver's primary organ, filter that plasma and filter the blood. When we're looking at platelets, platelets are fragments. Fragments, basically pieces of that megakaryocyte. When we're looking at the megakaryocyte, that is the cell that produces platelets. When we're looking at platelets and how they work in the body, basically they aggregate. That's the first thing that happens. We have some injury there. An injury to the tunica, to the intima, to the internal lining of the area. The platelets aggregate in that area and they start that clotting cascade. 80% of the platelets that we have in our body circulate through a thing. We only have about 20% of them that are stored. And of course, when we have a patient who is on Coumadin, we're going to look at that APTT results. We're going to make sure that we have them higher than that 20 to 36 seconds because we actually want them to take longer to go ahead and coagulate. Some of the other two things that we're going to look at is fibrin degradation product, and probably one of the most common fibrin degradation products that we look at is that D-dimer when we're looking at those coagulation studies. Some other coagulation disorders that we can look at are definitely liver disease. We have cirrhosis, we have hepatitis, we have basically anything that's going on that's causing a liver disease. We can have a disruption or a decrease in the clotting factors. Some other coagulation disorders that we can have can be specifically related to anticoagulation therapy, specifically referring to heparin-induced thrombocytopenia. When we're looking at a patient who has heparin-induced thrombocytopenia, we're looking at a patient who has been on heparin. We're looking at a patient who very well could have any type of heparin. Most of the time it's that unfractionated heparin, and they could have been on heparin up to 100 days prior to having any type of this signs and symptoms. And what they get is a thrombocytopenia related to this heparin induction. Platelet count is definitely going to drop. We have thrombosis. We have thrombosis after that heparin exposure. So they're going to have a lot of different various clotting going on. So when we're looking at treatment for the heparin-induced thrombocytopenia, we have to treat them for these thromboses, and we definitely have to give them anticoagulant type medication. However, of course, we're going to stay away from heparin because that's what got us in this position in the first place. But we're going to look at that definite direct thrombin inhibitors are the medications that we're going to go ahead and give them for that disorder. And another disorder with coagulation has to do with DIC, or disseminated intravascular coagulation. Some of our patients who are at big risk for this, pregnancy, once they've delivered, you remember hearing about DIC in OB. Also our patients who are in sepsis, shock, cancer, anyone who's had any large tissue trauma, severe allergic reactions. So basically what happens is what we're going to find is that they're basically going to have prolonged PT, PTT, elevated FDP, elevated D-dimers. We're going to see bleeding in 3 unrelated sites with this. Basically with DIC, we're going to treat that aggravating cause. So basically they have a bunch of different coagulation going on. There's a variety of different things going on. They have a lot of different prolonged bleeding times. Different things can happen. They can happen to the point where they actually develop multiple clots and that causes an issue. They can also come up with a point where they actually go into DIC. They use up all of their clotting factors, and then basically they bleed out those various different sites. So how we care for them, definitely we treat whatever's causing it. If it's an allergic reaction, it's a sepsis, we cure that, thereby curing the DIC. For nursing care with any of the patients who are at risk for bleeding, whether it's going to be from the different thrombocytopenias or from DIC, definitely gentle care, right? We don't want to cause them injury. We don't want to cause them bruising because they're going to be at more risk for that. For the patient with DIC, they are on a heparin drip, right? We're trying to prevent any further coagulation. They get fluids. Oftentimes they get FFP and platelets administered to them. We went over blood products a little bit in advanced pharm last semester. Some of the blood products that we can administer to our patients in the hospital setting, we can administer whole blood, packed red blood cells, platelets, FFP or fresh frozen plasma. Then we have some other blood products that we may be giving, granulocytes, cryoprecipitate, albumin. Those are all considered blood products. And there's different considerations and nursing considerations that we need to look at when we're administering these various different types of blood products to our patients. If you're going to be administering whole blood, we definitely need to look at that ABO compatibility that we looked at last semester. When we're talking about whole bloods, they contain basically the whole thing. It's blood just like our blood. So it contains those RBCs, those white blood cells, the platelets, the electrolytes. We rarely use whole blood. Okay, sometimes when we're using whole blood, units whole blood, those are the ones we're going to do for rapid, massive blood replacement. So these might be our patients who have been in a trauma, right? We need to replace not just components of their blood, right? Not just the red blood cells, but actually the actual volume of the blood also. So those are the type of patients. So we don't use it a whole lot. 1 unit, if you're going to transfuse a unit of whole blood, usually it's about 500 milliliters of volume that you're due. So you're going to get 500 milliliters of intracellular volume. In addition to it, you're going to get those replacements of all those cells that are important for perfusion. Packed red blood cells. They do need the ABO compatibility, so they need to match the donor versus the recipient, or at least the donor needs to not be contraindicated for the recipient. So remember all those A's and B's, and they can only get A or B. However, they can get O, but an A cannot get a B, and all those rules apply. When we're looking at those plaque red blood cells, mostly red blood cells that are in the unit of that, very, very thick and viscous. They can be modified, meaning they can be washed, right? We can wash certain things out of them. They can filter them out for white blood cells depending on what the patient needs it for. So that's an important thing with the packed red blood cells. So they can get the red blood cells, but basically we can wash out anything that we don't need. Usually this is what we use in symptomatic anemia. So when you are transfusing in the hospital, majority of the time what you're administering to your patients is the packed red blood cells. When we're looking at a unit, we're usually looking somewhere around 250, 300 milliliters in a unit. So that's the volume of the unit. Once we administer a packed red blood cell to our patient, the hemoglobin is going to go up a little bit. It's going to go up about 1 gram per deciliter for every unit of packed red blood cells we see. And then, of course, associated with that, you're going to see hematocrit rise. Hemoglobin rises, so of course the percentage of the hematocrit is going to rise. 2 to 3% per unit is usually the hematocrit increase that we see after a unit of packed red blood cells. We can also transfuse platelets to our patient. If we are transfusing platelets, even though platelets are a blood component, we don't need to worry about the ABO compatibility. Mostly what's in platelets are platelets. We can have a random donor versus single donor concentrates. What that means is we very well, because there's no need for any ABO compatibility, we can get a unit of platelets that has come from multiple donors, meaning multiple donors have actually given blood. They have separated out the platelets. So we may get platelets from various different people in one unit, or we can get a single donor who's actually donated units of platelets. We use platelets and we infuse platelets to control or prevent bleeding on our patients. Because if we increase their platelets, if they're low, if they have bleeding, more platelets to aggregate together and start that clotting cascade. If they're low platelets, we can give them platelets so if they do have an injury, they won't bleed because they'll have the platelets they need to start that clotting process. When we give a unit of platelets, we're usually looking at an increase in the platelets of about 5,000. When we're looking at the volume that we're infusing for platelets, about 200 or 300 mLs is the volume of that bag. Another component that we can give to our patients is fresh frozen plasma. When we're looking at fresh frozen plasma, once again, this is a blood component that does need ABO compatibility checked. Mostly plasma is what's in fresh frozen plasma. So basically it's those electrolytes, clotting factors, fibrinogen. We use FFP for people who have active bleeding, some sort of deficiency in their clotting, or prophylactically for a procedure with a lot of bleeding. So if we have a procedure that we're going to do, perhaps the patient's blood pressure is a little bit low, maybe their platelets are a little low, perhaps they're going to go in for a large procedure, maybe an open heart surgery, maybe an amputation. They might give them fresh frozen plasma ahead of time because of that risk of bleeding so that we don't have that. When we look at 1 unit of fresh frozen plasma, basically we're going to increase or raise those clotting factors by about 2 to 3%. Volume of a unit of fresh frozen plasma is going to be about 200 milliliters. We call it fresh frozen plasma because it is stored frozen. We do not give it to the patient frozen. We have to thaw it out. We do have to give it immediately after we thaw it, and once we thaw it, we have to use it within 24 hours. Can't refreeze it, so basically once the fresh frozen plasma is ordered and it's thawed out, it can't be put back in the freezer. So some alternative things that we can do besides transfusing our patients with blood or from blood components from a blood bank or from a donor are patients that may use their own blood. Sometimes with elective surgeries, a healthy patient can actually donate their own blood and have that blood used during surgery. Another thing that we can do is something referred to as cell saver methods. Sometimes during a procedure where we may lose large amounts of blood, we can actually collect that blood from our patients and retransfuse it. We use this procedure a lot during traumas sometimes. If a patient perhaps has a chest wound, if it's a clean chest wound, and basically they have large amounts of blood being emptied into their chest area, their chest cavity, what we can do is put in a chest tube, collect their own blood, and then use that blood and actually transfuse it back into them. One of the things that we do with that definitely is when they collect that blood then, and they're going to use it for that means, there has to be heparin or anticoagulation in the bag that we use. It's nice and easy because of the fact that both of these procedures decrease transfusion reactions. If we're giving them their own blood, we have a much less chance of having any kind of transfusion reaction. Basically, we decrease the ABO compatibility issue because they're getting their own blood. We also decrease disease transmission. Now, blood donation and receiving of blood, it is definitely better in years. They do check for disease process. However, it is not completely fail-safe. When you consent or have your patient witness the consent for the blood transfusion, they're presented with information from their doctor regarding why they need it, but we also give them pamphlets, information that talks about the possible risks of disease transmission through blood transfusion. In addition to this, some of these banked or saved blood, it doesn't use the blood supply. We hear every year, you'll hear on the news, during certain seasons, there's a depletion in the blood supply. So there'll be a call for people who can donate blood, who normally do donate blood, to go ahead and donate that blood. Some of the complications that we can have with cell saver method is emboli. We can have an emboli actually introduced back into the bloodstream from a clot formed in the blood. We can have hemolysis of the blood. So if we actually hemolyze or break down that blood components, we have the blood components that are released into the body. Definitely worried about potassium. Probably one of the biggest concerns we have with the hemolysis of the actual blood. And thrombocytopenia. We can have a drop in those platelet counts as a reaction to receiving that blood. All right, remember the blood types, review your ABO groups and your RH factors. The HLA groups are basically the name that's given to those antigens on platelets and white blood cells. So you may be giving your patient some blood in the hospital. Normally the lab will come down and they'll type in cross to try and decide before they can then transfuse. So they have to realize and they have to understand the patient's blood type and the RH factor. In addition to that, they check for those antibodies, those indirect and those direct Coombs tests. Now, if your patient doesn't have a lot of antibiotics or something like that, a lot of times the blood will be typed and crossed and you'll get your blood relatively fast. If your patient has a lot of different HLA groups come up, antibodies, antigens present, it's going to take you a little longer for them to find an appropriate blood type. I can tell you in the hospital that it has taken me upwards of 24 hours for them to find an appropriate blood type for the patient. That was a rarity. Usually it's a little bit longer, a few hours or so, but for this one particular patient, it took that long to go ahead and find an appropriate blood type. All right, so when we're going to go ahead and give our transfusing for the patient, basically we give transfusions to our patients when they need volume, right? They've lost blood, they need blood volume. Perhaps it's because they need oxygen carrying capacity. They need more red blood cells, right? Maybe they need, they are anemic. They need more hemoglobin. We need to raise that up. Or perhaps they need clotting issues. Maybe they are thrombocytopenic and we need to give them a transfusion to actually raise those clotting factors. Definitely some of the risks with patients transfer is reactions. We can have a reaction with a blood transfusion even if we have done everything that we thought we could to make it right. They've been typed in cross. They were given the right kind of blood. They were given the right blood comparing with the antibodies that are discovered. Errors and reactions can happen. When we're looking at errors, if you saw anyone in last semester transfuse blood, as students you can't, it takes 2 licensed RNs, but errors occur. There's incompatibility regarding ABO compatibility, various different things. So 2 nurses should check that right before they give it. They check it at the bedside. They check it against the order for the doctor, against the patient's wristband, against the donor unit. So all of those things are in place. Even with those things being in place, sometimes errors will still occur. Another risk that we have is that disease transmission. Patients can receive diseases from the transfusion of blood products. All right, some of the transfusion reactions that can occur when you're giving blood or blood components are allergic reactions, bacterial, febrile, hemolytic, circulatory overload, electrolyte imbalances, and then we have our 2 big pulmonary transfusion reactions, Trolley and Taco. All right, so an allergic reaction that can happen, what happens is there's an allergen in the blood, or the blood is sensitive to the patient's medications. And we're going to see signs and symptoms like an allergic reaction. We're going to have itching sometimes, hives, fever, anaphylaxis, typical allergic sign reactions. And it's a reaction to that because the patient's going to get these signs and symptoms during the transfusion. Usually it's going to be very quick after the transfusion. We're looking at this allergic reaction 5-15 minutes into it, you might really start seeing this. What do we do as nurses? With any kind of reaction to blood, you're going to stop that transfusion. Stop that transfusion and disconnect the blood tubing. When you disconnect the blood tubing, you're going to start saline in that line, and you're going to call the doctor. When we're giving it, we're going to give that patient, if they've had this allergic reaction, they're going to get vital signs every 15 minutes until they stabilize. Sometimes what we're going to give them is antihistamines, maybe diphenhydramine. They possibly may need other medications that we give for allergic reactions. They might need some sub-Q epinephrine, possibly some corticosteroids like Solu-Medrol, basically all of the medications that we give to stop allergic reactions. In addition to stopping the transfusion, disconnecting the tubing, and starting the saline, you wrap up the blood that was given and it is sent back to the blood bank. So it's sent back with the paperwork stating that the patient had an allergic reaction, and that way they test that blood and they try to determine what it was in that blood part that caused the allergic reaction. With a bacterial reaction, there's an organism in the blood. Basically what you're going to see is much like a bacterial invasion in the blood for other things. You possibly are going to see your patient who has chills, fever, abdominal cramping. They might have some GI issues like vomiting, diarrhea. Sometimes it can be more severe. Patient may go into a shock type situation and acute renal failure. Same thing is going to happen with this reaction, with any other reaction. Stopping that transfusion, disconnecting the tubing, running saline through the line, calling that doctor, monitoring those vitals every 15 minutes until that patient is stable. For epinephrine, corticosteroids, oftentimes for the bacterial reactions. In addition to that, we may start broad spectrum antibiotics. Send that blood to the blood bank for testing. A febrile reaction. Most times when we see a febrile reaction, this is HLA antibodies. So what we have is antibodies in the blood that is actually responding to antibodies that were present in the patient. Patients are going to complain of chest tightness, sometimes a cough, some flushing, chills, fever, flank pain, headache, tachycardia. Same concept, stopping that transfusion, send the blood back to the blood bank for testing. Sometimes what will end up happening, we will either, for the next transfusion, get an HLA match for those antibodies, or we possibly will give the next transfusion, and the doctor will order it with a leukocyte filter. Or sometimes we may go ahead and give another transfusion, and the next time they may go ahead and pre-medicate with Tylenol or diphenhydramine. A lot of times when we're transfusing blood or blood products, it is part of the protocol of the hospital. We go ahead and administer that Tylenol and that Benadryl ahead of time. And what that does is it prevents these type of reactions from happening before they happen. It's not going to stop them if it's a severe reaction. However, if we give that medication ahead of time, we can prevent it from occurring. With a hemolytic reaction, this is where we have an ABO or RH incompatibility. It can also happen with improper storage of the blood. We might see blood oozing from the site of the IV, burning along the vein that the patient's complaining of. They're going to complain of chest pain, fever is there again, chills, flank pain, hypotension, perhaps bloody urine, we're going to do the same thing, stopping the transfusion, disconnecting the thing. For hemolytic, one of the things we're going to do is when we start that saline, it is going to be lots of saline that we're going to be giving them. We're going to call that doctor. Vitals are the same, Q15 minutes until they're stable. After the transfusion, we're going to send urine and blood from the patient to the blood bank. We can give them epinephrine if they're having that shortness of breath, things along that side, O2 sat dropping, anything along those lines. We're going to give them oxygen. Definitely give them fluids, vasopressors sometimes. We need to go to the fluids and then the vasopressors because of the hypotension. We're also going to monitor the patient who is having a hemolytic reaction to blood for DIC, disseminated DIC is going to be a reaction, a severe reaction to the hemolytic reaction. Another reaction that our patients could have for receiving blood components is circulatory overload. They may be getting too much blood and too fast for their body or their cardiovascular system to handle. This is a big concern when we're actually transfusing blood or blood components to our elderly patients, perhaps our patients with cardiac disease. They very well may complain of difficulty breathing, chest pain, jaw pain, fever again. If you notice, fever continues to appear over and over again. It is one of the things that we check when we're transfusing blood. Right when we first do it, 5 minutes and the 15 minutes, that's included with the vital signs check because of the fact that that's one of our first signs that we may see. With a circulatory overload, patients might complain of a headache and hypertension. Basically, they're getting too much fluid volume at this point. Some of the things that we can do for them is to stop that transfusion, sometimes slow it down. We perhaps are giving the transfusion too fast for their cardiac system to actually compensate for that. And of course, we're going to call the MD. A lot of times with a circulatory overload or a patient that we suspect might have circulatory overload, such as they're going to get 2 units or 3 units of packed red blood cells or something along those lines. A lot of times the doctor is going to order diuretics given between the units of blood. The reason for the diuretics is to get rid of that extra fluid. So we will possibly overload them a little bit, give them those diuretics, get all that fluid off. We're still maintaining the components of the blood, but we're actually getting rid of that overload. If the doctor happened to order whole blood, we might want to consider packed red blood cells. With packed red blood cells, we're getting those red blood cells, we're getting those components of the blood, but we're not getting that extra whole blood volume that we would get. Some of the electrolyte imbalances that we might see with blood transfusions, hyperkalemia. We talked about possible lysis of the red blood cells as they're transfused. Remember, when we have those cells that break down, potassium would actually be released into the bloodstream. So we need to look for all of those possible signs and symptoms that we're looking at with the patient who's hyperkalemic. Of course, we all know as soon as we say hyperkalemic, the first thing that comes to our mind is those peak T waves. We also have different other arrhythmias that can occur, cardiac arrest, patient with flaccidity of the muscles twitching, and acute renal failure. If we have these type of signs and symptoms going on, same thing, we're going to stop that transfusion, start the saline, call the doctor. Those vitals, call labs and EKG. To get rid of the hyperkalemia associated with that, we're going to look at medications that we use to get rid of the potassium. K-oxalate to bind with the potassium and excrete it through the stool, glucose and insulin to bring it back into the cells, and mannitol could be used. Another electrolyte imbalance that we can see is hypocalcemia. What occurs with the hypocalcemia is there is citrate in the blood component itself, binds with the calcium, and thereby drops the calcium level in the serum. Usually we see this with our patients who get FFP. Those are the patients that most often we see become hypocalcemic. Arrhythmias can happen, hypotension, patient can get cramps, nausea, vomiting, and seizures. So you're going to see those signs and symptoms that you normally see with hypocalcemia. Oftentimes with this, we're going to slow the transfusion down a little bit, vitals, call the doctor, labs, IV calcium gluconate. So basically, we're taking the calcium away from them with the FFP. If we also give them IV calcium gluconate, then we can give that calcium back to them. I also do want to mention at this time that there are the 2 articles that are readings for this week's topic. You have an article that is loaded onto Canvas regarding DIC and also the pulmonary reactions related to blood transfusions. So those are 2 articles that you'll need to read that will go further in depth with DIC, as well as these 2 reaction criteria, the trolley and the taco. When we're looking at trolley, it is transfusion-related acute lung injury. It is going to be lung injury that is not related to cardiac, not non-cardiac, and it is pulmonary edema, and it is following the transfusion of blood products. We're going to see trolley within the first 6 hours after the transfusion of blood products. Trolley is immune-mediated. So when we're looking at trolley, we're basically looking at an inflammatory process that is related to the immune system. The way that we're going to treat trolley for our patients is going to be oxygen, mechanical ventilation. We're going to have to give these patients fluid and vasopressors. They need that fluid to try and maintain that blood pressure. They also need those vasopressors. We are not going to give our patients with trolley diuretics because they actually need more fluid. It's not a response to the fact that they got too much blood and they're in any kind of circulatory overload. It's an immune-mediated response. So basically, it's an inflammatory type thing. So diuretics is actually going to make them worse. It's going to make their pressures worse, and it's not what they're going to need. And no corticosteroids. Corticosteroids have not proven to be necessarily effective in the treatment of trolley, so we don't necessarily give them. The other transfusion-related pulmonary reaction is going to be referred to as TACO, transfusion-associated circulatory overload or volume overload. Basically, because of the blood transfusion, it is cardiogenic pulmonary edema following a transfusion of blood products. We usually see this within 2 to 6 hours of the transfusion of the blood products. They're going to get acute hypertension. They're going to get dyspneic and hypoxic. We're usually going to see TACO in patients with cardiac disease. So this is the circulatory overload specifically related to the blood. What we're going to do for these patients is basically going to be some respiratory support. We're going to make sure we position them, head of that bed up, right? Help increase oxygen for them because they are going to be hypoxic. With TACO, they are going to get diuretics. It's an overload problem, so we need to get some of that fluid off. So diuretics are common in the treatment of TACO. In addition to that, some of the other things that we may do for them is phlebotomy. They may take out some of that blood, right? So we think of phlebotomy, a lot of times we think of them coming in, taking blood for lab tests. In this case, we're taking the blood off to make them better, right? We've given them too much blood. They've had this reaction and put them in pulmonary edema. We take the blood out and reduce that workload. In addition to that, we can also possibly look at a CPAP machine or assist with their breathing with some end expiratory pressure or PEEP in there. We are going to go over ventilators. We are going to go over CPAP and PEEP in a couple weeks. But just know that that CPAP machine to assist with their breathing is definitely going to be a treatment that we use to help with that TACO. So remember, this will conclude the end of the presentation. Looks like I've been talking for about an hour, which is quite a long time. Make sure that you come in with anything that's not clear or any questions and ready to answer those questions. You also should have come in reading the 2 articles, and we'll be ready to discuss anything that comes up with those 2 articles. And we should be ready to go ahead and do some case studies and actually bring it into the clinical picture. All right, I will see you guys all Monday, whether you're in the 7:30 or the 10 o'clock class.